Well, thank you everyone for your patience. We'll make sure we get to everything, and we're excited to bring this to you today. So we're talking all things bone density, the basics and beyond. I'm Dr. Lauren Young. I'm a naturopathic physician that practices in Manchester, Connecticut, and I'm actually medical staff with ECHN, which I'm super proud of. And Dr. Kage, would you like to introduce yourself?
Yes, my name is Barbara Kage. I am a board certified rheumatologist. I'm also a very proud member of the staff of ECHN, and I'm very happy to welcome everybody and to learn more about osteoporosis.
Awesome. I apologize. My dog always likes to show up for these things, guys. So we are going to go through, we have a lot of information. We honestly could make this a two-part lecture. So what I would ask is if you have any questions, please feel free to drop them into the chat, and then we will at the end go through and make sure we address all your questions. We're going to try to do a deep dive into what is bone density, why does it matter, how do you get diagnosed, what are the risk factors, and what do you want to do about it, both conventional and natural treatments. So we're going to do a deep dive into bone and even like some of the physiology of it. But really the important thing to know is that our bones are living things that are constantly being turned over and strengthened in response to our environment. And there's a lot of things that will tell us whether or not we should be making stronger bones or weaker bones. Our nutrient level in our diet, our stress levels on our body, how much we use our bones. A lot of things tell us whether or not we should be making dense bone or thinner bone. And that really will play out to a lot of things because it's going to translate to risks for fractures and other issues, especially as we get older. So there's these little guys, and pardon the histology, but we're science nerds, right? So there are osteoblasts and osteoclasts, and basically they are building up the bone and breaking down the bone all the time. You're always turning over your bone. The bone that you have now is not the bone that you had when you were a teenager. So what we're doing is setting the pace for what we should be building up and how much we're breaking down. So you think about bone density is really about balance in your life. It's about, are you building up more or breaking down more? Are you more anabolic or catabolic? And so we really look at it from that perspective, that like we want to create balance for the body, and that when the body is out of balance and you have a thinning of the bones, they're less strong than they used to be, it's hard to get back in balance. And so that you want to be really proactive on that. So again, I showed this slide because yes, you have a peak bone mass, but it's not like you can't build bone. I mean, you're going to be able to, your bone's always turning over and building up and breaking down. That's always happening. But what we found is that kids are amazing at building up bones. They heal bones beautifully if they ever have a broken bone, and they're built for growth. They're building up. As adults, we're more breaking down, right? So our bones are going to hit a peak in our 20s, typically, peak bone mass, which is a lot of times genetic. I don't love this slide because it says genetic peak bone mass is not always just because of poor lifestyle choices. It can just be genetic. And sometimes it has to do with choices in our life. So that peak is going to be there. And then after that, we may drop off. And especially for women, as we hit menopause and estrogen leaves our bodies, or there's less estrogen in our bodies, we're going to have more of a drop off there as well. And so we really want to set a good foundation, really build up our bones as much as possible and feed them all the good stuff that we're going to talk about tonight. So we were talking about genetics being a risk factor. A lot of times our family members aren't necessarily like handing over their medical history. And so even having a parent with a broken hip or a parent with a lot of fractures as they were older, that may be a risk. So the ones on the left, especially these risk factors, I don't have to read the whole script to you. You guys are going to get these slides. There's not a lot you can do about your age. It's a risk factor. You can't change that. Fracture history, gender, these are things that are, we are predisposed to fractures because of certain things. And also certain medical conditions like rheumatoid arthritis, actually celiac disease, even when you are gluten-free. There are a lot of things that put you at risk for bone density issues that have nothing to do with anything, just who you are, you're just be more prone to it. If you're on certain medications because you need to be because of a condition, that's going to put you more at risk. And so those aren't things we can modify, but they are things that can make us be mindful of like, oh, we need to make sure we're taking care of our bodies a little extra and paying attention to our bones because we are at risk. The list on the right, we can definitely clean. We can make sure we're getting enough calcium and nutrients. We can avoid cigarettes and reduce alcohol and caffeine. And then sometimes there are medications that we can adjust and go into other things if we know we're at risk for osteoporosis. So all of these things may have some things we can work on, making sure our body weight's good, our muscle mass is good, that type of stuff. So we think about all of this stuff when we think about who should be screened and who's more at risk for bone density. And so these are just some guidelines. If you have a lot of risk factors, even if you're a man, you should be getting screened for bone density issues. If you have a family history of like a father with a hip fracture, for example, that's something to be thoughtful about. I think we think of this a lot for women, but it is certainly an issue for men as well. And then these are just some guidelines from different groups on who should be looking at getting tested for bone density issues. Take it away, Dr. Kage.
Okay. Just to reiterate, osteoporosis is the most common metabolic bone disease in the US and in the world. And it is characterized by decreasing bone mass and deterioration of bone tissue. It is a silent disease, so we don't have any inkling that something is happening to our bone integrity until it is complicated by fracture. Those fractures are quite painful and place an enormous medical and personal burden on individuals and take a significant economic toll. They are quite common worldwide. An osteoporotic fracture occurs every 3 seconds. That's common. Among patients in the US, age 50 and older, about 10 million people have osteoporosis, and 43 million, so about over 10%, people in the US have osteopenia, which is a low bone mass that has a high risk of progression to osteoporosis. Next slide. So once the fracture occurs, it is associated with excess mortality. A hip fracture is associated with 25% excess mortality within the first 12 months, usually due to immobilization and related infections, pneumonias, etc. And it is also associated with 25% excess mortality over 5 years after a lumbar spine fracture or vertebral fracture altogether. Interestingly, osteoporosis-related fractures in the spine occur in the thoracic spine and lumbar spine, but not in the cervical spine. What a patient perceives as an unfortunate accident may be seen as a sentinel event indicative of bone fragility and puts person at increased future fracture risk, even if the original fracture is a result of considerable trauma. A lot of the times when we have difficulties ascribing a given fracture to severity of the trauma, I ask my patients if they would have broken a bone given similar circumstances if they were in their 20s or 30s. And if the answer is probably not, then we should think that it might be indeed an early indication of bone mineral density loss. An underappreciated result of osteoporosis is increased risk of dental loss. There are data showing very clearly that women with osteoporosis tend to have fewer teeth than women with normal bone density. Next slide. And this is a familiar picture of patients as we age, and the change in the silhouette can be related quite often, not always, of course, but quite often, to the change in the architecture to the bone. To the left side, you can see dense bone with strong bridges between trabecular bridges. And on the right-hand side, you see a decrease in the number of those bridges. And I'll have another slide that will show the fracture, microfractures of these bridges. And this is on this slide. If you look on the left-hand side, that's a normal bone mineral density. That's how it should look. And on the right-hand side, those trabeculae, those bridges are frequently broken. Quite surprisingly, a number of those fractures and microfractures are clinically silent. So the person might not even feel that they have a fracture, especially within the spine. And we just see it on x-rays, and sometimes a person just notices a hump. Next slide. And this is how it looks on the cellular level, what Dr. Young alluded to, described earlier. Bones, for all their strength, are in constant motion. They are living structures that undergo constant remodeling, comprised of two phases. The phase of resorption, carried out by cells called osteoclasts, that take the old bone away. And that is followed by osteoblasts, bone-forming cells. Under normal circumstances, that process takes about 12 months, and the net result is filling up fully those bone losses, so no net loss. However, if osteoporosis occurs, usually the resorptive phase is more active, and we end up with net loss of the bone. And usually that process is ongoing. So as you can imagine, over time, over the years, it's progressive. And this is one of the newest insights that in the pathology of osteopenia and osteoporosis, that these processes are progressive and chronic. Next slide. And this is once again just a statement about osteoclasts that remodel the bone, resorb the bone, and osteoblasts are the ones that move in and produce a bone matrix that calcifies. This is important to remember, and please remember that cartoon, because it will be of great relevance to therapeutic interventions that we'll be talking about later. Next slide. And this is what we see on x-rays. So to the left, that is that the red lumbar spine, that's how those vertebrae should be looking. And this is on the actual x-rays, we see those biconcave fractures or wedge compression fractures with our unfortunately the complication of osteoporosis. And this is what we see sometimes on MRI, also very well visible wedge compression fractures in the middle of the skeleton. This is a thoracic spine. Next slide. So we would like to diagnose osteoporosis before a fracture occurs. And the best diagnostic test for that is DEXA. This stands for dual energy X-ray absorptiometry. Next slide. This is regarded to be the most useful, easy, inexpensive, and first-line tests that help diagnose osteoporosis. These scans use a low-level X-rays that go through the body and yes, that's the slide, and measure how dense our bones are. Next slide. And they actually measure the amount of calcium and other minerals, and then translate it into density expressed in grams per centimeter square, and then put it against the population, large populations of age-matched, gender-matched controls, and come up with something called T-score, which is a standard deviation of the bone mineral density of the individual compared to the person who is 30 years of age, at which time we feel there is a person has the highest bone mineral density and the lowest chance for low impact fractures. Of note, these scans are very safe. The amount of radiation used in DEXA is very low, about 1 to 4 microsieverts. By comparison, the dose for a chest X-ray is about 20 to 50 microsieverts. We frequently compare the DEXA scan-related radiation to the amount of radiation we get on the plane traveling from Boston to Chicago. Generally, radiology technician does not need to wear any protective outfit. Of course, for pregnant patients, this is nevertheless not recommended. Next slide. And these are T-scores and that Dr. Young, I like this presentation very nicely. So we look at the T-score, which is in green normal. And it is -1 to +4, etc., standard deviations. And then we have a group of patients that are not exactly osteoporotic, but they are not, their bone is not exactly of normal density, and it's called low bone density or osteopenia. And T-score is between -1 and -2.5. When the bone mineral density is measured as T-score of -2.5 or worse, it's consistent with osteoporosis. And both low bone density, so osteopenia, and osteoporosis can lead to low impact fractures. So even a person who has just osteopenia can be at risk for fragility or low impact fractures. Next slide. So that just briefly summing up the T-scores, so normal -1 or better, osteopenia between -1 and -2.5, and osteoporosis -2.5 or worse. And here we have one more category, and this is severe osteoporosis. So this is osteoporosis of T-score -2.5 and fractures. And that group of patients requires slightly different treatment. So I'll be talking about it later as well. Next slide. When talking for person who has osteoporosis, treatment is always indicated, because once you get that T-score of -2.5 or worse, it is associated with such high risk of fractures that all the medical societies out there recommend treatment. But for patients who have low bone mineral density, so they have just osteopenia, for those patients, we want to know who is that person that would benefit, who is at risk at fracture and would benefit from treatment. So a number of years ago, a group of researchers in UK came up with fracture risk assessment, later adopted by World Health Organization, so it's WHO FRAX, that uses measurement of bone mineral density in the hip, and especially the neck of the hip, and puts it together with a number of other risk factors, like having a parent who had a hip fracture, or having a personal history of low impact fractures, or having condition like rheumatoid arthritis, which is an independent risk factor for fracture, or taking prednisone, especially at the dose of 5 milligrams a day for 3 months or longer, or smoking or drinking 3 or more alcoholic drinks per day, or having secondary osteoporosis due to, for example, having celiac disease or inflammatory bowel diseases, or hyperparathyroidism, which is an overactive parathyroid. And then they put it all together and come up with a number that gives us a risk of fracture over the, and we are talking about low impact fractures, over the ensuing 10 years. Next slide. For people who have fracture, WHO FRAX of 20% for major osteoporotic fracture, or 3% for the hip fracture, this is the group of osteopenic patients who require treatment. This slide actually also specifies and that there are other definitions of osteoporosis besides T-scars. So these are patients who already had fragility fractures. So clinically, their skeleton declared itself as being susceptible and went through the fracture. And then those fractures, not all fractures are ascribed to osteoporosis. So the ones that we do think of are vertebral fractures, proximal humerus, hip fractures, pelvic fractures, but also wrist fractures and forearm. And in particular, what does not constitute osteoporotic fractures are toe fractures, foot fractures, hand fractures. They just have they are under different, they are more like stress fractures, and they don't belong to osteoporotic fractures. And next slide. In the previous slide, we had a specific line for patients who are at very high risk for fractures. And so all the others are at the high risk. But at the very high risk fractures are patients who have osteoporosis plus have 1 or more additional fractures.
38.
Already. And number 2, the person who just had a fracture, that person is at much higher risk for a next fracture within the first year than a person who didn't have even a fracture, even with the same T-scar. If the person is already treated with for osteoporosis and yet fractures, again, that risk for the next fracture is very high as well. And the patients who have fracture while on bone-harming medications, for example, long-term steroids, anti-seizure medications, those are at high risk. And then going back to bone densitometry, patients who have T-score of worse than -3 and have high FRAX score, so major osteoporotic fracture, MOF, over 30%, comparing to over 20% for high risk. And for hip fracture, over 4.5%, as opposed to over 3%.
No,
Those are at very high risk.
tomorrow night.
And that
Oh,
group,
actually, yeah.
will be that very high risk patients. Please commit it to your memory, because they will require a different therapeutic approach, especially at the beginning. Next slide. So that's once again pretty much summarizing what we've just said about the high risk fractures patients. So when we are confronted with the diagnosis of osteopenia or osteoporosis, we recommend a set of laboratory tests to evaluate for secondary causes of bone density loss. Next slide. And we have a standard blood tests and urinary tests to look for those causes. So we evaluate for CBC, presence of anemia, or any other conditions that can cause hematological malignancies, for example. Chemistry profile to check for whether the person is not having chronic renal insufficiency. Parathyroid, PTH, overactive parathyroid, and TSH, so overactive thyroid, if the number for PTH is elevated or TSH is very low and the person is having hyperthyroidism or Graves' disease, those are endocrine causes of bone density loss. A vitamin D deficiency, 24-hour urine calcium, but also phosphate can inform us about conditions where kidneys, for example, instead of reabsorbing calcium, might be actually wasting it, and the level of calcium in the urine might be elevated, and that would require a slightly different therapeutic approach. If phosphate level is elevated in the urine, we might look for hereditary conditions like hereditary hypophosphatasia, where alkaline phosphatase is low and vitamin B6 is high. Hence, that's at the bottom of the second column. For men, we check testosterone. We check celiac disease. Yes, celiac disease, even well controlled with diet, is a risk factor for malabsorption and bone mineral density loss, a pretty common cause. Prolactin, cortisol, other endocrine conditions that might present with unexpected bone mineral density loss. In terms of finding out how bad that bone turnover is, we measure certain bone turnover markers just to have a baseline information. And next slide. So I feel that this slide is very important and reflects the current and recent thinking in about osteoporosis and osteopenia. So number one, it's pretty obvious. no uniform recommendation applies to all patients. Patients have, everyone has a slightly different situation and medical situation, and management plans must be individualized. The second very important thing is that while current medications build bone and decrease a bone breakdown and dramatically reduce incident fractures, which is all wonderful and very helpful, we still do not have a cure for this disease. So all the anti-fracture therapeutics that we have to our disposals have been very helpful in managing the condition and preventing major complications, but we do not have a cure. That once again emphasizes my previous point of this condition being chronic and progressive. As soon as those anti-fracture medications or medication is discontinued, the skeletal deterioration resumes sooner or later. It is later for bisphosphonates, and it's definitely sooner for almost every single non-bisphosphonate medication we have to our disposal. Next point. Maybe we can go back. Even if normal bone mineral density is achieved, osteoporosis is still present and elevated risk for fracture is still present. So that means the diagnosis of osteoporosis persists even if subsequent DEXA shows improved T-scores. That's an important thing to remember. It would give us a segue to thinking that we need to monitor that disease and not to be surprised if there is a fracture, because we can catch it earlier if we find that bone mineral density is decreasing. And of course, Dr. Young will be talking about it further. Pharmacotherapy is not the end of the management. There are a number of lifestyle modifications that will need to be added for successful therapy. Next, and next, please. When you think about that cartoon showing bone resorption and bone formation phases, I would like to bring it to your attention because we have therapies that target that resorptive phase and slows it down, and it's with anti-resorptive therapies. And we have the therapies that improve the effectiveness of the bone-forming cells, osteoblasts. So in the first group, we have bisphosphonates, and I'll be talking about them more, denosumab or Prolia. And we have raloxifene or Evista that belongs to selective estrogen receptor modulators. This is the medication that works only for decreasing vertebral fractures only and not other fractures. So we don't use it very often. It is for postmenopausal women only. But it is a good option if we don't have other, when we are out of options. And another FDA-approved treatment is estrogen plus minus progestin therapy that was shown to reduce risk of hip and vertebral fractures. But it is no longer used except in women intolerant of other drugs because of the significantly increased risk of breast cancer, stroke, venous thromboembolism, and perhaps coronary artery diseases. And among anabolic therapies, we have parathyroid hormone-related medications that you might know under names of Forteo and Tymlos, And the newest addition to the anti-osteoporotic treatment is romosozumab or Evenity, that was approved in 2019. It does have a black box warning of increased risk for cardiac ischemia and stroke, so it's not for everybody either. And next slide, please. And this is a snapshot of currently FDA-approved osteoporosis medications. So in the first line, we have alendronate, risedronate, ibandronate, rarely used nowadays, and zoledronate, which is an intravenous medication. And as you can see, it's used, this group of medications, these are so-called bisphosphonate, are used for postmenopausal osteoporosis for both prevention and treatment. For steroid-induced osteoporosis, both prevention and treatment. As you can see, there is no age or gender limitation. And they're also helpful for male osteoporosis. Raloxifene is SERM for women only, estrogen, as described. Calcitonin is really no longer used. It's we used it when we didn't have bisphosphonates. And Prolia, denosumab, I'll talk about it a little further. So this is up until the red line. These are all anti-resorptives. Below they are anabolic, so bone growth stimulating medications, bone density stimulating medications. So bisphosphonates impair this is the list of them, and they impair osteoclast activity and restore better balance between bone resorption and bone formation. Next slide. The American College of Rheumatology, the American College of Physicians, and American College of Endocrinologists, National Osteoporosis Foundations, all these medical societies strongly recommend initial therapy with bisphosphonates in males and postmenopausal females diagnosed with primary osteoporosis. And the American College of Rheumatology strongly recommend initial therapy with bisphosphonates as well in patients on steroids for prevention of steroid-induced osteoporosis. This group of medications has the most favorable balance among benefits, harms, patient values and preferences, and cost. A lot of these medications are available over the counter. I'm sorry, not over the counter, in the generic form. And what I really wanted to say that some of them can be even obtained through Mark Cuban cost-priced pharmacy, which is endorsed by the American College of Rheumatology, since they have a lot of generic medications at the very affordable cost. Excellent. Very good. So a few words about denosumab. So about the bisphosphonates, we usually give them for 5 years. And then people take the drug holiday, so to speak. But if the patient has a contraindication to bisphosphonates, for example, has Barrett's esophagitis or has allergy to bisphosphonates, or has renal insufficiency sufficient to avoid bisphosphonates, we recommend denosumab or Prolia, which is a fully human monoclonal antibody. It is one of the anti-resorptive medications. And next slide. It is given as a subcutaneous injection every 6 months. It has it was found that should we skip the dose or delay dosing of denosumab beyond 8 months, it is actually associated with paradoxically increased risk of fractures. So precise dosing intervals should be observed. And likewise, at this point, there is no limitations on how long denosumab can be given. However, if at some point we are satisfied with the bone mineral density and decreased risk, and we would like to stop treatment with denosumab Prolia, then it is recommended that a course of bisphosphonates is given to seal in the bone mineral density increases and to prevent fractures, as per concerns above. So this was the therapy that we would initiate for patients at high risk for fractures. Now, patients with very high risk for fractures, so those with T-scores of -3.0 or worse, major osteoporotic fracture risk at 30% or more, and hip fracture of 4.5% or more over the ensuing 10 years per fracture risk assessment. We actually start with anabolic treatment medications, either parathyroid-related medications, teriparatide Forteo or abaloparatide Tymlos, or romosozumab. They are superior in protecting this group of patients from fractures. They produce higher increases in bone mineral density and better protection from both vertebral and hip fractures. This group of medications, however, has a time limit on their therapy. So the first-line teriparatide and abaloparatide can be used for maximum 24 months and have to be followed by bisphosphonates or Prolia, denosumab, to prevent rapid decrease in the bone mineral density that happens upon stopping these medications. And a similar situation is with romosozumab. This medication is recommended for maximum 1 year, although it can be repeated, but that therapy has to be followed by bisphosphonate. Next. So this is maybe one extra point about this group of anabolic agents, Forteo and Tymlos. The good news is that in November 2020, FDA removed a black box warning on these medications for risk of osteosarcoma. They acknowledged that that risk does not exist in humans. It was observed in growing baby rats, but it was never documented in humans. And Forteo was approved in 2002, so 21 years ago. Abaloparatide a little more recent. So nevertheless, it's a very welcome FDA action here. And next. So these are daily injections for 2 years. Romosozumab is a monthly injection, subcutaneous, and it's definitely not for those patients who had any of those major events like cardiovascular events like MI or stroke. It says within last year per New England Journal of Medicine publication from a few years ago, but in our clinical practice, we all avoid those medications for patients with that cardiovascular profile. Next. So to summarize, anabolic agents are better to improve bones mass and microstructure and reduce fractures. And they are recommended as a first line for severe osteoporosis, patients at very high risk for fractures. They do need to be followed up by anti-resorptive agents. Next slide. This is also a very important slide that reflects the current thinking and guidelines and management of osteoporosis. So the question is what to do when the initial osteoporosis therapy is discontinued. Because now we know that this is a chronic disease and patients may lose bone down the road and become and fracture or experience fracture. So we check the bone mineral density and see whether the person is at low or moderate risk for fragility fracture, osteoporosis related fracture, or is that person at high risk? So if we are the group of low or moderate risk and our initial therapy was bisphosphonate, either oral or intravenous, no subsequent osteoporosis therapy is needed. That is not forever, it's just for a number of years perhaps. It needs to be monitored. SERM, selective estrogen receptor modulator, right, like Raloxifene or Avesta. No subsequent osteoporosis therapy is needed. For parathyroid-related medications, Forteo or Tymlos, we follow those 2 years of therapy with either bisphosphonates or if the situation requires it, then first denosumab and then followed by bisphosphonate. If we started with Prolia, then we follow up with bisphosphonates and ramosuzumab, Evenity, same thing, you follow up with bisphosphonates or denosumab followed by bisphosphonate. So one way or the other, when we have the anabolic medication, we follow them by bisphosphonate, by some anti-resorptive medication. And at the end, every single medication is followed by bisphosphonate, with the exception of SERM, perhaps. Next slide, please. So if the initial therapy, osteoporosis therapy, is discontinued and patient remains high at high risk, we have number of options. We can switch the current therapy. We can continue current therapy. There is, as I mentioned, before at this point we do not have the limitation on how long the patient can stay on denosumab, or we can switch to intravenous bisphosphonate, or once again recycle parathyroid. That is somewhat controversial at this point, whether we can, after first 2 years of either Tymlos or Forteo, whether we can ever reuse them. There is a growing data body of evidence that's safe, but it has not made it into official recommendations. And we spoke about that before. So next slide, please. And then we want to ask, does sequence of medications matter? Yes, and these are a number of studies showing that that's indeed correct. That's really predominantly, next slide, for showing that anabolic medications should be tried first. it is once again predominantly for patients who are at very high risk for fractures. In very select situations, we can use them for other patients. Next one. And these are just a few clinical trials showing that teriparatide and Tymlos are definitely better than placebo, and they are also better than bisphosphonates as an initial therapy for those, especially for those patients with very high risk. And next slide. And similar data for romosozumab. And next slide. And that's another number of studies, another slide showing that especially for those very high risk, where that applies. If we were to start with bisphosphonate first and then said, aha, we really want something more aggressive, like teriparatide, for example, that response of the bone is not as robust to when we do bisphosphonate followed by teriparatide, as if we tried it the other way around, teriparatide followed by bisphosphonates. And that's what informed the guidelines for people, for patients at very high risk for osteoporosis. And next slide. So how do we monitor response to treatment? This is a very strong recommendation that we do it with bone densitometry. There were clinical trials that tried to assess whether there is any predictive value to measuring bone turnover markers or many other laboratory markers, and none of them was as predictive, or nearly not even close, as bone densitometry. So when we follow the therapy with DEXA, we recognize that the good response means either stable or increased bone mineral density. So even if the bone mineral density is not increased, it's just stable, we already declare victory, because in the clinical trials, we saw that those patients with stable bone mineral density still had significant decrease in the risk of fracture. The worrisome response is when there is bone mineral density decrease, and that would trigger reviewing the diagnosis, doing the lab work to find out what else is going on, and consider switching the therapy. Next slide. So every patient who faces starting the therapy wants to know, for all good reasons, how long the therapy should last. So we have data now that shows that when we start with bisphosphonates, the therapeutic benefit starts after a year, then increases and plateaus at 5 years. So we usually recommend 5 years for oral bisphosphonates, and the response is a little faster and a little more robust with intravenous zoledronic acid or reclast. And then we recommend taking maybe a few years of drug holidays, monitoring it with bone densitometry, let's say every 2 years, and considering reintroducing the therapy if there is a significant bone mineral density loss, especially if it is on more than one occasion. So that's, we already spoke about denosumab data, Prolia, that at this point there is no limit. FDA does say that 3 years of teriparatide might be helpful. I have not seen that in practice yet, but hopefully that will come. And we have some data on safety of the recurrent use of romosozumab, meaning taking it for a year, taking at least a year off, and then consider resuming it if the person remains at high risk of fracture or if the fracture occurred. So one of the reasons why we ask how long the therapy should last is because we have some safety signal, especially with, so for anti-resorptives like bisphosphonates, but also with Prolia, so denosumab, and also we had cases already in romosozumab. The patients had episodes of osteonecrosis of the jaw. That is an extremely rare complication. For bisphosphonates, it is as uncommon as dying by lightning strike. But nevertheless, it is a pretty unpleasant, not life-threatening, but pretty unpleasant complication. Atypical hip fractures with anti-resorptives occur. They are atypical because they happen and the hip bone femur slightly distal to the place where other types of fractures occur. And the risk goes up after people are on it for more than 5-6 years. The good news is that the risk returns to baseline after 1 to 2 years of bisphosphonates, but bone benefit remains. So yes, here we have some problems with the bisphosphonate holidays, and mainly related to a rapid decrease of bone mineral density. So close monitoring of these of patients is helpful. And next slide. So a few more words about the osteonecrosis of the jaw. Most of the episodes of ONG in the setting of bisphosphonates occurs with intravenous medications. So I would like to remind everyone that Reclast or zoledronic acid is used for osteoporosis at the dose of 5 milligrams once a year for 3 to 5 years. But exactly the same medication, zoledronic acid, is used at 4 milligrams a dose intravenous infusion every month by oncologists for prevention of bone metastases. Nevertheless, those ONJs go under the therapy with bisphosphonates. So it is a rare complication. I routinely recommend completing invasive dental work prior to initiating treatment. And then we recommend maintaining dental hygiene while on therapy. Next slide. American Dental Association actually issued official statement saying that for regular dental work, including extractions, we do not need to pause treatment with bisphosphonates. And once again, American Dental Association also recommends importance of routine dental care adherence. Next slide. Yeah, that's pretty much we've already covered. And please, next slide. Another adverse reaction with, by the way, for patients who had osteonecrosis of the jaw, if the conservative treatment doesn't help, sometimes we need to give those patients anabolic medications like Forteo or Tymlos. Another poorly understood complication of anti-resorptive therapy is atypical hip fracture. It happens very rarely, and it has a sometimes it's fairly asymptomatic, so we recommend for all our patients who start any of these medications to report to us if they should develop any new discomfort, vague pain around the hip or thigh, or both, can be bilateral. Those, because that indeed can signify a fracture. So we do not really fully understand how it happens, what's the etiology of that complication. We have some thoughts about how to treat it if the person continues to need treatment for osteoporosis, clearly avoiding bisphosphonates and probably denosumab as well. So maybe that would be the situation when we can use raloxifene or estrogen-based therapy for women. Next slide. And this is, this slide shows an increasing risk of atypical fracture of the hip with duration of bisphosphonate exposure. So we're pretty safe up to 6 years. Beyond it, that risk is increasing. Next slide. And Dr. Young, maybe you'd like to take over from here.
Yes, absolutely. Thank you so much, Dr. Kage. I learned a bunch of things to listen to every time, so this is really helpful. And it also just emphasized why it's so nice to have someone at the helm who understands all these medications and understands interpreting DEXAs, which is a wonderful thing to have all in one with you. So we're going to talk all things supplements. Dr. Kage found this study and kind of wanted to bring it to our attention. It was in a quite prestigious journal last year, New England Journal of Medicine, where they found that essentially taking vitamin D did not make a difference when it came to preventing fractures, which is ultimately our goal with bone density. And so she kind of brought it as like, what's going on with vitamin D? And I quickly was like, you know what, this is a perfect spot for you to segue into me, because I truly, bone density is not one vitamin. It's not just calcium, for sure. And we're going to talk about a lot of these nutrients, but these are all the nutrients that play a role in making our bones, let alone all the other aspects of our life that can impact our bone density. So I want you to think about baking cookies in your kitchen. If you're baking cookies in the kitchen, you need to have all the ingredients, probably some other tools and that type of thing. And, you know, not a chaotic kitchen, so you can actually focus on baking. You need a nice oven, you know, so these are the metaphor is like your body has to be able to lay down bone well, no distractions from either medications, inflammation, other things that could be playing a role that'll be throwing off your thing. But you need to have all the building blocks to make that. I mean, we were looking at these beautiful structures that Dr. Kage had shared with us, and we need all those building blocks to be able to make that tissue. And so we will dive into some of this. Appreciating everyone's time and bedtime and such, I want to summarize a couple things, and you certainly will get all of these slides, and we're happy to triage all the questions. For example, there was a study showing that giving calcium along with zinc, copper, manganese, and silica is better than just doing calcium alone and improved bone density more. So think about what that means. That means that, you know, if you had making cookies, we'll say gluten-free flour, you know, I like eggs, milk, whatever. You have all the ingredients, but you do just the flour, you're not going to get quite as many cookies. Something's going to be the rate limiting step for building this bone density up. So if you have all the minerals and really getting it from a whole foods diet. So bone density from a nutritional standpoint is not one nutrient. There are nutrients that are very commonly deficient in our diet. And so I want to make sure we do a deep dive on those today. And that's what we'll be doing, the first 5 there. Really quickly too, the other thing I want to speak to is the folic acid, B12, B6, and vitamin C. One of the markers that is not always screened for is homocysteine. From a naturopath's perspective, I know Dr. Kage had it on her list of things she looks at, which I love. Homocysteine is a sign of how your body detoxes, and it's elevated if you don't have certain nutrients, specifically folate. Folic acid is the synthetic, or methylfolate if you have genetic mutations where you don't utilize folate well. B12 and B6 are some of the main nutrients that help lower your homocysteine. Homocysteine is correlative with increased risk for osteoporosis. And so it's something functionally that we can test, see improved, and help reduce your risk of bone loss. And so that's one of the things that doesn't get looked at a lot. And we're not going to do the full deep dive, but you can test homocysteine and it functionally looks at metabolically, where are you at with your B vitamins and how that'll impact your bone density. Vitamin C is on this list, and it's not also going to have a deep dive tonight, but that is really important for collagen production. Collagen is part of the bone matrix and extremely important. And there was a question that I'll triage now and just say, like, yes, collagen as a supplement has been shown to be beneficial for bone density. We'll kind of do a deep dive into why. It's a protein, and that will help with it. So real quick, because there's a lot of studies out there, and there's very pro ones, anti ones. I just want to talk about how to critically look at vitamin studies on a whole, because they're we're not funded the same way as medications, right? And so the research comes from a couple different places. A lot of times it's correlative studies where correlative is like, oh, we noticed they both went up at the same time, or that one went down and one went up. That doesn't mean causation. And so you'll notice the ice cream scoop there. Example I'm going to give you is ice cream sales is correlated with increased risk of polio and incidences of polio. Ice cream has nothing to do with polio. We all know this, right? But polio had more exposure in not necessarily oceans, but more in lakes, and there was more exposure to polio in the summertime when you would eat more ice cream. That correlation has nothing to do with each other. So there's a lot of those type of studies, and we instantly extrapolate from that, like, oh, it means my bone density is better, or it means it's worse, or that means it doesn't do anything. We really have to think critically of what these studies are saying. Secondly, the other studies that are great examples are prospective or retrospective or cohort studies where there are massive amounts of people. We're watching like 16,000, 30,000 women who are postmenopausal over a 10, 20-year period. The problem with that is there's a lot of biases and confounds. So give an example of that. The calcium with vitamin D study in the Women's Health Initiative, they found that it did make a difference taking calcium or vitamin D. Well, if you drilled down into the study and pulled out the marker of like how many people were actually compliant with the study and actually taking their calcium every day with their vitamin D every day, then it was actually a huge improvement for their bone mineral improvement. So another example would be like sometimes there'll be correlations with certain nutrients and increased risks for cancer or stuff like that. The people who are already being proactive may be the ones that got the screenings, that got the diagnosis. It doesn't mean vitamin D caused something. So we just want to really think critically when we're looking at these studies. It can be really helpful, but unless it's double-blind placebo, that's kind of the gold standard where the doctors don't know who's got what, the patient doesn't know who's got what. That's the group to study to really get information. So I just want to give you guys that quick little tutorial because there's a lot of stuff in the news these days because, right, this is a big condition and we want to think really critical about it. So calcium, everyone says take calcium. Calcium is extremely important, but it's not as important as everyone thinks. It is a big piece of the puzzle. pun intended there, because it's also a big mineral. But it is a piece that we have to think of critically. How are we getting it into our body? Are we absorbing it? And it has gotten some bad press recently, and I want to be able to talk to that a little bit because I saw a couple questions about it, because there have been some research around it being increasing risk for cardiovascular disease. So I'll address that with the dosages. So what form is best? It is important what form we put calcium in. Minerals like this don't like to just float around as easily. You can get elemental calcium. I don't recommend that as a dose. You want to get it bound to something like a chelate. And the other example of a really common one is carbonate. Calcium carbonate is essentially like Tums or chalk. It's basically very chalky. It is a very cheap form of calcium, and it doesn't absorb very well. So this is one study broke down the absorption rates for calcium carbonates versus chelates. I personally like calcium chelates a lot better. So the calcium's bound to like a citric acid molecule or malates, or it's bound to another ingredient and it'll absorb a little bit better. Calcium is a big honking molecule. It is hard to get absorbed. And so we want to think about making sure we're getting it in. Other things, if you have a risk of kidney stones, calcium potentially could be a way to reduce that risk by doing a calcium citrate. They've shown that taking citrate forms of minerals can actually reduce your risk of certain types of kidney stones. Not all, so I'm not prescribing that to anybody, but talk to your doctor about it. And again, we want to be mindful of like, how is the absorption of your GI tract? How are your gastric acid levels? Because this is going to be important when it comes to the absorbing these supplements. So, so that one study basically showed that the supplements only work if you take them. And then this study shows that they need to be a better quality. We have a joke in our office because the reps will come in and tell us about different supplements or whatever, and everyone's got the best calcium, right? But like, in my mind, it can be, it doesn't have to be a super fancy one to get a good amount of absorption. The other thing is we want to think of, when we're thinking about how much calcium we should get every day, we really need to take into account food sources. The biggest thing with food sources was, right, the dairy industry did an amazing job at promoting themselves as a source of calcium. And it is a good source of calcium, for sure, for sure. Some people can't have dairy, and you know, certain foods, especially like almond milk can be really high in calcium. Vegetables are too. So there's a couple things to think about when it comes to the calcium you're eating. I thought this was really interesting. Like, yeah, bok choy only has 180 milligrams, but it's very bioavailable, and it's actually about the same amount of absorbed calcium as a cup of like cow's milk. So that bioavailability, there's not like graphs on that for everybody, but the take home message is, if you look at this list, it's whole foods and leafy greens and in general are very good sources.
This is Dr. Kage. I cannot.
Barbara, I hope you don't mind.
I'm just looking at that screen, and my screen is has frozen, and I can't hear Dr. Young. Do you know what's?
Barbara, we can hear you. Sorry. So hopefully everyone else can hear me. Give me a thumbs up in the chat. Calcium hydroxyapatite. I'll just handle that question while we're because I'm seeing it while we're going. That is another form that's supposed to be well absorbed and also to help with that matrix. Oh shoot, I can't go backwards suddenly. I sometimes use that. The research is kind of mixed. Honestly, most of the research are done on calcium citrates and malates, and then it can be very effective. And I'm not sure it's worth the cost difference in a lot of cases. I haven't seen it personally, like clinically, make a huge difference for people's bone densities compared to like, you know, driving the old reliable sedan versus the high-end sports vehicle. I'm not sure it makes a difference when it comes to brass tacks. The biggest thing again is like, a supplement also has to augment your diet. So if you're eating a lot of these foods, you're actually getting a pretty decent amount of, you know, if you look at these things, if you're getting a decent amount of this stuff daily, you're having a good source of greens, you're getting some like dairy or non-dairy sources of calcium, and you could be getting a good amount. And so this is what they're recommending, base of total calcium plus diet plus supplementation. This is what it should be. I want to point this out because there has been some research with increased risk of cardiovascular disease. All of the research showed that it was over 1,500 milligrams a day that people were getting in their calcium from the study. And so basically they looked at women who were supplementing with calcium and they were getting a ton of calcium in their diet, and that was increasing their risk of cardiovascular disease. So I don't think it's one of those things where taking calcium alone, like if you look critically at your diet, that could be fine. It's not in your multivitamin. So a lot of people are like, well, I'm taking a one a day. Calcium is a huge molecule like we were talking about. And so you're going to have to take it separately. I also recommend taking it away from other foods because it's going to either get inhibited for absorption, especially foods that contain oxalates or phthalates. They're so a lot of green veggies, actually, that's the anti-nutrient I kind of was making a reference to. They're not going to, it's going to inhibit the absorption a little bit. So I like taking my calcium with a ratio of 2 to 1 to magnesium, and we'll talk about that. Sometimes 1 to 1 to magnesium because magnesium is the best thing ever. And so you want calcium with magnesium away from other medications and supplements. I like doing it before bed because magnesium helps you relax anyways. And you really got to talk to your doctor about what the dosage should look like. And it should be, again, looking at the whole picture of like diet plus supplementation, not just blindly doing supplementation of that amount. So the other thing to be mindful of if you're taking a calcium supplement is a lot of them contain vitamin D now because vitamin D is the darling of the medical world as far as nutrients goes. It can be toxic. If it's vitamin D, we'll talk about it, can be toxic. So just check your calcium to make sure it's got vitamin D and just count that towards your vitamin D as well if you're doing that. So there were some other questions on like specific calciums. I would point everyone to go look up one of my mentors. She's out in California. She graduated in like the 80s as a naturopath, and she's like purely does women's health. Her name is Tori Hudson. And I think she's the bee's knees, and she has a great blog on everything women's health. And I really go by that because she does the deep dives in the research and she critically thinks about it. And she, puts it together in a really nice, succinct way. And so there's a lot of things like the coral calcium was a trend for a while. There's algae-based calciums. The coral calcium, there was a lot of concern of like where they're harvesting this stuff, and also are they testing it for heavy metals? So again, with supplements, you really want to make sure they're good quality. And I've found no benefit from getting whole foods supplements for calcium versus not. But if someone's finding something that's agreeing with them, because calcium can be a little binding to the GI tract, and if you know it's a good quality, it could work for you. But I would say, she says no algae-based or no coral-based calciums, and I think she's smart. So magnesium is a tremendous mineral. It is not found in our soil the way it used to be, and so therefore not in our diet the way it used to be, and therefore not in us the way it used to be. And it is incredibly important from everything from our anxiety to bone health, metabolism. It plays an important role in utilizing vitamin D. And again, with getting calcium into the body, once you put it into your GI tract, it still has the job of getting into your body, and then another step of getting into your bones. So we have a lot to look there. There's some pretty great studies with looking at just supplementing with magnesium. They found improved bone density scores and reduced hip fractures within like a year. It did plateau and didn't change more. I think it repleted people, and then they got to utilize their nutrients better. So again, when we're cooking, you need your flour, you need your sugar, even the naturopath saying that. So magnesium is one of the key ingredients to getting calcium into your body and building that bone matrix up. Incredibly common deficiency, can be tested for in blood work, not as an ion, but actually a red blood cell magnesium. And symptoms of low magnesium would be muscle cramping, anxiety, heart palpitations, which are symptoms of a lot of other things, but it can be signs that like you're low in magnesium. Constipation is another one. So magnesium is something you want to look at. And if you thought calcium had a lot of different variations, man, magnesium loves to marry up to everything. There are a ton of different types of magnesium out there. So what's the best type? It's a cost benefit ratio with a lot of this stuff. So I would say oxide would be like your first car and when you're 16, like probably a little bit of a beater, not that great, it gets the job done, but nothing to write home about. Not my favorite. Magnesium citrate is a really common one on the market, and I would say that's these are not in order of quality, by the way. I'm just picking out a few of the common ones you'll see. Citrate is great because it can also help if people are constipated, and it's not that expensive. So those are really nice things about citrate. The chelated ones, glycinate and threonate, those three at the bottom are probably my favorites. The citrate, again, can play a role in reducing risk for kidney stones. Glycinate is actually the amino acid glycine, which can help you feel more calm. And threonate has some research that magnesium can actually absorb the best with threonate, but it is a little more pricey. So magnesium can come in all sorts of forms. And I would say, citrate or the bottom three are my favorites. But again, some of these other ones are certainly fine. That was a lot of magnesium. I'll dive back to the questions afterward. Zinc, everyone knows zinc now thanks to COVID, right? Because it was supposed to help us fight COVID. So now we all know about zinc. Zinc is awesome for a lot of things. Again, an extremely common deficiency. And I think that, again, we can test it in our blood work to see if we're low in zinc. And I think that's an important thing. It competes with copper for absorption. So you don't want to take zinc long-term high doses indefinitely. But when we think about zinc, we're thinking about bone growth, growth in general, helping skin, skeletal, like muscle skeletal. And it also can help with mood. It has a lot of different roles in the body. Minerals are so important for every aspect of our bodies, but it is a key component and has been shown in of itself at being helpful for helping with bone regeneration. So getting those osteoblasts to do their thing. So vitamin K is one that you'll see a lot with supplements, and if you like pick up a bone supplement at the health food store. And so I just want to do a quick little 101 of vitamin K. There's actually a third one, vitamin MK7, which is another variation, which has got some research on it too. But these are the two most common ones that there's a little bit of a misnomer with. K2 does not interact. So K1 is found in leafy green vegetables, and it plays a role with blood clotting with the medication warfarin. And so it can, you want to be careful if you're on that medication with being on K1. That doesn't play as strong a role with bone health as K2 and MK7 do, which are really derived mostly from gut bacteria, but also found in foods like Gouda, natto, which is a Japanese fermented soybean or fermented bean. It's very umami flavored. There's a little bit in blue cheese and eggs. So foods that maybe sometimes we're eating every day, but I don't know if we're getting the amounts of K2 that we're really aiming for to use therapeutically. So sometimes I'll have people on K2, which has minimal interactions with some of those other medications, and they get nervous that it's going to affect their clotting, and K2 doesn't really have to do with clotting. So this just talks about how K2 works in the body. It is basically needed for a protein that is going to draw calcium into the bone and provide the calcium for the bone matrix for mineralization. So like think about it as like opening up the doors for your bones to actually utilize the calcium you're taking in. And again, with those correlative studies, we have seen when your K2 is low, you've got an increased risk of fractures. Is that causation or correlation? I mean, it's not causation, it's correlation, but it is that we do find that this is an important piece of things that we want to think about. I would think of this as the vanilla in your cookies. It's crazy how a little splash of that can make a huge difference for helping bone support. We can't not talk about vitamin D. This is our other fat soluble vitamin. Vitamin D is so important for bringing calcium from our intestines into our body. It actually has been shown to reduce parathyroid hormone and induced resorption. So like it slows down the breaking down of bone just in and of itself having adequate levels. It's not adequate in our diets. I've definitely had people, I know there's that picture of salmon and that's great. You'd be eating salmon all day long to be able to get enough vitamin D. And so we get it from sunlight, which will be coming soon, but it's not here yet. And so our body will make about 10,000 IUs if our skin is exposed to sunlight for about 20, 30 minutes arms and legs, not midday sun. And there's obviously contraindications for that. Like if you have an autoimmune disease that's exacerbated by the sun, if you have a history of melanoma, there's like reasons why you might not be able to get sunlight. And so you might be better off doing a supplement. This is fat soluble, this supplement. So that means it's toxic if you have too high a doses. You see that now because there's so many on the market that you can do a really high dose. Some people need a higher dose because they're not absorbing it well. Some people don't, and then they end up with huge levels. Or you'll see a liquid one and it'll be like a drop full and they've been taking a dropper full. So the signs of too much vitamin D are headaches, nausea, vomiting. You feel the worst headache of your life. And the problem is it's fat soluble. There's not much, you just kind of, hopefully we get it out. It can also throw off your calcium levels. It's not something we want you to have happen. So I will say in my years of practice, I've seen high out of range levels, and I've never seen anyone to have to go to the emergency room for it. But you don't want to just go willy-nilly on your vitamin D. There's two different types of vitamin D. There's D2 and D3. D2 is also known as ergocalciferol. It is a it's a vegan form of vitamin D, usually derived from algae, and it does not convert into what is in our bodies, which is D3 or cholecalciferol, which cholecalciferol is sourced from either sheep have it in their wool and in the lanolin, and they'll pull the lanolin's fat, right? So they'll pull the fat out of the sheep's wool and source the lanolin from there. Or they'll find it in fish oil and they'll pull it from there. So again, fat soluble things because it's a fat soluble nutrient. So the interesting thing with vitamin D is it's not just about bone density when it comes to vitamin D. At the end of the day, it's our bones. It's important to have healthy, thick bones, but it's also about not falling and not fracturing anything. So they've found that your kinesthetic intelligence is better when you have an adequate amount of vitamin D. So you'll have more balance just by having adequate vitamin D, and that there's reduced risk of falling, increased muscular strength, all good reasons. It's actually a hormone. We could do a whole lecture on that. I know it's already late. So I want to do a touch on a couple more things, and I want to give a little bit of time for questions. And this was with me skipping a lot of things, guys. So we could probably do a part 2 if you want on just other functional medicine stuff or other deep dives from Dr. Kage. There's a lot of dietary stuff recommendations out there. If you notice the list, high protein, low protein are both listed as correlative with helping prevent bone loss. So what do you make of all that? Here's what I'm going to tell you. What my take on it is. There's a lot of different studies. They'll say like a vegetarian diet's better, where there's a lower protein level and higher vegetables, and they'll say a high protein diet is better, and this is why. So teasing through the research, here's my 2 thoughts. Whole foods diets, lots of minerals, making sure you're addressing any deficiencies you may have, and avoiding anything that's going to make your body more acidic, because then your body's going to have to use some calcium to buffer that. And I'm not using that in your blood. Your blood is very well controlled, acidic and basic. It's actually your GI tract we're thinking about with this. So avoiding sugar, soda, super bad for your bones. Those would be easy things to cut out. It's not the carbonation, it's the other nutrients, not the nutrients, the other stuff that's in the soda. So you could do a stevia-based one or a seltzer, and those haven't been studied to be a problem. So because it's the other additives in soda that increase the loss of calcium, which is things we don't want to see. So that my take-home message would be eat lots of vegetables and have a good amount of protein. I point people to a lot. This is from Johns Hopkins website. They've got a great thing doing a lot of research on protein and bone health, protein and everything pretty much. And this is kind of their recommendation on what you should be aiming for amount of protein in your diet. So I would point you to Johns Hopkins website for that. There's a ton of information and protein calculator, that kind of thing. A couple other little things I just want to do is that, like, I think weight bearing people have different takes on that. And so yes, we should all be out walking every morning. It's hard sometimes in the winter. So what are we going to do instead? We got to keep our bodies moving. The National Institute of Health, or NIH, has done a tremendous amount of research on yoga. There's a lot of grants out there for a while on yoga. And so what we've found is some really interesting research that yoga alone can really make a big difference on the health of your spine and your femur. And look at that, it also is going to reduce risks of falling over because your balance is going to be better. So you can find my patients in when you're waiting at the grocery store. If they're standing on one leg, they probably see me because they're standing in front of the cart. And when you stand on one leg, the weight that you're bearing is throwing it onto that one femur, right? Which is the biggest risk. We don't want to break a hip. And so doing that is the equivalent of walking for 53 minutes when it comes to weight bearing exercise. So I just wanted to dispel the myth that like, yeah, I mean, for sure, I think, you know, ask your doctor for a referral for PT to like learn how the body mechanics work to be able to make sure you're really doing good weight bearing exercise. But in the meantime, when you're at the grocery store, you can stand in tree pose or on one leg or unipedal standing, as they say in a lot of the studies, and you're going to get some benefit on that one hip. It's going to have the equivalent of a little extra weight on that one leg, and it's going to help. There's a great article called Why Flamingos Don't Get Osteoporosis, and it was written by my friend, and this is one of the great little perks from it. Lastly, so there was a really interesting study looking at air pollution and bone density, which is again a risk factor that's outside of our control, but it just speaks to like that breaking down, building up process we were talking about is systemic, and it can be inflammation and oxidative stress and so many other pieces of things that we're just learning about. So making sure you're addressing every aspect of your body and environment as much as possible can really make a big difference when it comes to bone health.